Yes, sir. We are on live, sir, and we am starting the session, sir. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. First of all, sorry for the delay in starting this webinar due to some technical issues. It was delayed. I welcome all the participants. I request them to post their queries in the chat box so that we can have a short Q&A session at the end of this presentation. Now, the topic for today's webinar is evaluation and treatment of infertility. And now I'd like to welcome our invited speaker for the day, Dr. Baliram D. Parshiva sir. Sir is currently the medical director at Om Sai Hospital, consultant gynecologist at DM Petit Municipal Hospital. Sir is the joint secretary of IMA Vasai and member of IMA, MOX, FHOXI, FG, AIGE, AMC. Sir has received his gold medal in OG 1999, and Sir has presented various case presentation. In particularly, Sir has presented a bizarre myoma on uterus at Bhatia Vidyapith Pune in 1998, and Sir has done various paper presentation on our experience with modified laparoscopic sling for nulliparous prolapse at MOX conference 2004. So with this very short introduction, I welcome you, sir. I'm handing the session to you for further proceedings, sir. Welcome you, sir.
Thank you. Thank you, Shield, for giving me this opportunity. Again, extremely sorry for the delay because of some network issue from Shield side. So, not taking much time, I will be starting the session. Please. Are you able to see my screen?
No, sir. No, sir. Sir, you can just share your screen first, sir.
Yeah, I have shared screen.
Can you stop share and reshare again, sir?
Share screen. Bravo?
No, sir. Please click on the share screen.
Which
and
one?
Then in bottom, there is a share screen option, green color.
Yes, I have clicked on that.
And then a dialog box, you please click on the blue color share.
Share, okay.
Yes, sir. It started. Yes, we can see your screen. Can you please go to the slideshow mode, sir? Yeah, perfect, sir.
Yes, sir.
Thank you, sir.
So today's topic is infertility evaluation and treatment. So as all of you know, infertility means any couple who is trying for a pregnancy for more than 1 year, then it is labeled as infertile couple. If the age is more than 35, then we consider as a 6 month duration, and we need to evaluate this couple at 6 months of duration. The causes, basic causes of infertility, 40% cases male is the problem, in 40% cases female is the problem, and in 20% cases there is unexplained infertility. Many times in 20% cases all reports are male are normal, all reports of female are normal, still they are not able to conceive, and it comes under the unexplained infertility. So what are the different female factors? The commonest or most important factor nowadays is age, because nowadays there is a late marriage pattern in the career-oriented females. So as age advances, the fertility decreases. Again, there is a problem of weight nowadays. The increase, more the BMI, less the fertility. More the weight, less the fertility. Because of excessive career orientation, lot of stress is there in the couples. They are not involved in the family. They are stressful because of the job, because of the targets at the office place. Nowadays, addiction is increasing day by day. We are seeing a lot of couples who are addicted to smoking, drinking, hookah, ganja. So again, this is also one of the main factor for female infertility. Different infections in the females like pelvic inflammatory disease, gonorrhea, chlamydia, this again causes the tubal blockage or endometrial blockage, and it causes the infertility. Again, Cox is one of the leading factor in infection in India for infertility cases. Chronic diseases like COX, hypertension, diabetes, also decreases the infertility potential in the female. Other causes which are rare are congenital or genetic causes. Congenital or genetic causes means chromosomal abnormality, like leading to the uterine abnormality, Mullerian abnormality, absence of vagina, absence of uterus, absence of ovaries, absence of fallopian tubes. These are the different congenital diseases which are the reason for infertility. In males, again, addiction is one of the important. Again, second cause is inability to perform the intercourse, sexual dysfunction. Sometimes there is a premature ejaculation, sometimes there is erectile dysfunction, sometimes there is impotence. Varicocele, dilated veins which are supplying to the testes, also one of the reasons for male infertility. Genetic is also less. Infection, common infection found in, again, males are syphilis, gonorrhea, chlamydia. These also causes the infertility. Cancer is the rare reason. Trauma to the testes in the childhood or while playing or while traveling, also one of the reason for infertility. Congenital defects, congenital absence of vas difference is also leading to the obstructive azoospermia, and that leads to the infertility. So whenever couple comes to a clinic or whenever patient comes to a clinic, detailed evaluation of the couple is important. Not only female or not only the male is important. Sometimes only females come, so there is no need to test to my husband. He is perfectly all right. Only check me. Or sometimes male comes and he says there is no need to check to my wife. She is absolutely all right. But no, you need to evaluate both, because in 40% cases female factor is there. In 40% cases male factor is there. So while evaluating the couple, you should see the age of the couple, husband's age, wife's age, any family history of the infertility, any family history of the any diseases in the family, any past history of any disease, is she on some chronic medication, any history of trauma or accident in the past, any history of surgery in the past. Also, height and weight of the couple is important to know the BMI of the patient, whether it is less BMI, whether she is malnourished, whether she is overweight, or whether she is obese or he is obese. Hair distribution, in so many hormonal changes, there is effect affects hair distribution. In PCOS, there is most of the times there is hirsutism. In some genital disorders or in some chromosome problems, there is decrease in the secondary sexual character, decrease in the axillary hair pattern, pubic hair pattern. That is also important to see during the examination. Also, you need to see the breast secretion for a female, because if there is a raise in the prolactin level, then it causes the breast secretion. That is also one of the important factor to create infertility. Thyroid problems, you have to see for the thyroid swelling. Even if thyroid swelling is not there, hypothyroidism or hyperthyroidism is also one of the cause for the infertility. Secondary sexual characters, the development of the breast, development of axillary hairs, pubic hairs, developments of the gonads is also important factor while evaluating the couple. You have to see for the surgical scar. It is mainly, most of the times, gents have undergone some hernia surgery. That also leads to the male infertility. In females also, they have, whether they have undergone any tumor surgery in the past, whether they have undergone any uterus surgery or ovarian cyst surgery in the past. Coitus history. Nowadays, this history is very important. We are seeing lot of couple coming to our clinic for infertility. And if we take the coitus history, the coitus history comes to frequency of intercourse is once in a month or twice in a month or once in 2 months or 3 months. They don't get enough time to perform the intercourse because of their busy schedule. So in some, if the patient is lacking coitus or there is no history of coitus or there is very decreased frequency of coitus, the simple solution will be planned relation, and that will lead to the pregnancy. Local examination of the couple, local examination of the female and local examination of male is also important factor during the examination. Many times whenever we are examining male, we found the undescended testes in many males. So what are the investigation for female? The commonest investigation is sonography of the female to know the uterus, condition of the uterus, condition of the ovaries, condition of the fallopian tubes. Is there any cyst? Is there any fibroid? Is there any hydrosalpinx? That simple investigation, sonography, will tell you the brief outline for this problem. The common blood investigation are complete blood count, blood group, blood sugar, HIV, HbCG, HCV, VDL urine. HIV, HBCG, HCV is done because these diseases are transmitted from the mother to the baby. Also, these diseases are transmitted from the patient to her husband or from husband to patient. Whereas syphilis is one of the common cause of the infertility in many females. Recurrent urine infection is also cause for the infertility. Thyroid problem, T3, T4, TSH, whether patient is hypothyroid or hyperthyroid, again that is associated with the infertility. FSH, follicle stimulating hormone, luteinizing hormone are important female hormones. We have to see the ratio whether it is normal. In PCOD, we are seeing LH is raised too much as compared to FSH. Also, prolactin level increased in prolactinum also. If the prolactin levels are more than 100, then you should do MRI of the brain to rule out the prolactinoma, that is anterior pituitary gland tumor. AMH, this is also one of the very important tool in the investigation of infertility. Anti-Mullerian hormone. Nowadays, we are seeing low AMH in young patient also, 20 years old, 22 years old. We are seeing low AMH. Previously, in the start of the practice few years back, AMH was only done in cases of only elderly females, more than 30 or 28. But nowadays, we are doing AMH in all cases, and we are surprisingly finding low AMH in even 20-year-old also. Hysterosalpingography. This is the very simple old investigation to know the tubal patency, whether the fallopian tubes are patent, whether the uterine cavity is normal, whether there is any uterine mass. But it is a painful procedure. So nowadays, it is replaced by, in many patients, if your patient is affording, the HSG is replaced by histolaparoscopy. Histolaparoscopy means examination of the uterine cavity through hysteroscope and examination of the peritoneal cavity through the laparoscope to see any abnormality. Endometrial biopsy is done mainly to rule out the pox, tuberculosis. So HSG is very simple and old investigation. In first film, you are able to see the normal HSG, normal uterine cavity with both fallopian tubes with spillage of the dye. In second image, we can see the two bilateral hydrosalpines. In third HSG image, you are able to see some cavity fluid defect. It may be because of air bubble, it may be because of uterine polyp. In fourth image, you are able to see the irregular uterine cavity or irregular filling of the uterine cavity with the dye. It is most of the times it is associated with the Asherman syndrome. Asherman syndrome is most of the times happens because of the DNC or surgical MTP. This is the commonest complication of surgical MTP. In fifth image, you are able to see the septate uterus or bicornate type uterus, and in sixth film, you are able to see the uterus diadelphus. So, if the patient is non-affording, then this is the very important or very simple tool to know the mainly whether fallopian tubes are patent and how is the uterine cavity. Nowadays, hysteroscopy and laparoscopy is gold standard for the investigation of the infertility. In hysteroscopy, you have to examine the uterine cavity through the hysteroscope. So first image is the normal uterine cavity. We can see the two ostia at the top and uterine cavity is rooming. In second image, there is a small lump that is called as polyp. Polyp is present on the anterior wall. In the second image, polyp is present on the posterior wall. In the third image, the same polyp will be removed in the same setting. That is called as hysteroscopic polypectomy. In fourth image, we can see the septum at the fundus. Even in fifth image, we can see the septum at the fundus. In the same setting of the hysteroscopy, we do the septoplasty. We cut or excise the septum and we increase the cavity of the uterus. That is called as metroplasty. Second thing is laparoscopy. Laparoscopy is the inspection of the peritoneal cavity via the laparoscope. The first image, you can see the uterus, normal uterus, both sides bilateral silky structure that is called ovaries, and we have beside the ovaries there is a fallopian tube. In second film, you are able to see the uterus with two horns. So this is the picture of the bicornate uterus. In third slide, in third picture, you can see the adhesions above the anterior abdominal wall and ovary. These adhesions are most of the times because of pelvic inflammatory disease or sometimes because of the pox. In fourth image, you can see the big ovarian cyst lateral to the uterus. In fifth image, you can see the multiple fibroids over the uterus. And in sixth slide, you can see the fallopian tube with cyst, that is femoral cyst, or it may be because of hydrosalpinx. So in the same procedure, we try to operate this. If there is fibroid, we remove the fibroid, that is called as myomectomy. If there is cyst, we remove the cyst, that is called as cystectomy. Again, we do the dye test during laparoscopy. We instill a methylene blue dye from the mouth of the uterus cervix, and we see the spillage of dye in the peritoneal cavity. If the both fallopian tubes are patent, so there will be spillage of dye on both sides. That is called as chromoperturbation. If the tube are blocked, or if one fallopian tube is blocked or other fallopian tube is blocked, in the same setting, we try to open the tube. That is called as fallopian tube recannulation or recanalization. So different investigation of male are very important, and at most important investigation for male is semen analysis, and that to be examined by either a MD pathologist or best if possible, if embryologist is available in your area, then it is to be ideally checked by embryologist. The other basic investigation for male will be CBC, blood group, blood sugar, HIV, HbCG, SCV, vidal and urine routine, just to know the transmission of diseases from husband to wife. Semen analysis. The latest semen analysis according to WHO guidelines are very much different. In 5th edition, according to WHO, they have make different guidelines for normal semen analysis. According to that guideline, only 1.5 ml semen is considered as a normal ejaculate. The total sperm count per ejaculate is 39 million. Sperm concentration per ml is minimum 15 million. Total motility, forward progressive motility, late motility should be at least 40%. And percentage of normal sperms, morphologically normal sperm should be at least there should be 4% normal sperms. If your semen is checked by the embryologist, you will find the morphological abnormal sperm in large percentage. If your semen is examined by the pathologist, MD pathologist, you will find less morphologically abnormal sperms. So at Homsai Hospital, embryologist comes daily to check the semen analysis. So abnormal semen analysis, if the male is having abnormal semen analysis, abnormality may be in the count, decreased count, abnormality may be in the decreased motility, or abnormality may be in the morphology. If the semen count is abnormal, or motility is abnormal, morphology is abnormal, then further investigations are advised for the male. So further investigation mainly USG scrotum, sonography of the scrotum with Doppler to rule out varicocele. If there is a varicocele of grade 2 or higher than grade 2, most of the times they require a varicocele ligation surgery. Then hormonal profile is also important for these patients. Thyroid, FSH, prolactin to know the testicular failure, also to know the testosterone level, to know the levels, whether they are low or high. Also, you have to see for the E2 testosterone ratio. Also, we do the beta HCG in male infertile couples. Also, we do karyotyping in such patient to know the Y microdeletion syndrome. So treatment, if everything is normal, male reports are normal, female reports are normal, then we do the natural follicular study. Follicular study without giving any medication with plant relation, at least for one cycle. If there is we found there is a ovulation, then we tell the couple to try for 3 months. If they are unable to ovulate naturally, then they require a induction of the ovulation with the help of medicines. So what are the different ovulation induction agents? Commonly in the practice are used are oral drugs, that is clomiphene citrate and letrozole. Nowadays, tamoxifen is not much used. Injectable are mainly used for IUI or IVF. There are gonadotropins. Gonadotropins may be urinary, gonadotropins may be recombinant, and also general analogs are used for as an injectable for ovulation induction. So most commonly drugs are only clomiphene citrate and letrozole. Clomiphene citrate is a centrally active estrogen receptor modulator. The doses are 50 milligram. If patient is unable to ovulate with 50 milligram, then 100 milligram per day for 5 days. If patient is unable to ovulate with 100 milligram, then 150 milligram per day for 5 days. Preferably, you should start clomiphene citrate from day 2 of the menses or day 3 of the menses and give it for 5 days. But whenever you are starting clomiphene citrate, you should be very sure that there is no ovarian cyst in the ovary. So day 2 sonography or screening of the ovaries on the day 2 of menses is very must before starting any ovulation induction. We are seeing a lot of patients which were given blindly clomiphene citrate by someone without doing sonography or without seeing ovaries on the date of menses, and they come to us with a big ovarian cyst, or sometimes they comes with the ovarian hyperstimulation syndrome, and unnecessarily they land up with the surgery. So if you see the ovaries, status of the ovaries on the date of menses or day 3 of menses, if ovaries are normal, then you can give 50 milligram, 100 milligram or 150 milligram of clomiphene citrate depending upon the response of patient. Avoid clomiphene citrate in PCOS patient. In your practice, try not to give clomiphene citrate in a PCOS patient. Also, there is one case called as clomiphene resistance. If the patient is unable to ovulate with 150 milligram of dose of clomiphene in 3 cycles, then it is labeled as clomiphene resistant. In such cases, you can try letrozole. The commonest side effect associated with clomiphene citrate is anti-estrogenic effect that leads to the decreased endometrial thickness. Because of decreased estrogen, the endometrial thickness is decreases, and there is a polyfollicular growth. Multiple follicles are grown in clomiphene citrate. So there is a risk of ovarian hyperstimulation syndrome, which requires admission, hospitalization of the patient in PCOS patient. So you should use clomiphene citrate with caution in PCOS patients. Also, never start clomiphene citrate or letrozole blindly. Always do day 2 sonography or day 2 screening of the ovaries. Second drug very safely and very commonly used practice of infertility is letrozole. It is an aromatase inhibitor, less anti-estrogenic property. That's why the endometrial thickness is good in letrozole patient, and it causes monofollicular growth. So risk of ovarian hyperstimulation syndrome is less with letrozole as compared to clomiphene citrate. There are different doses and different schedules of the letrozole in the practice. Commonest use is 1 tablet of 2.5 mg per day for 5 days, preferably to be started from the day 2 of menses to day 3 of menses. Second is 2 tablets per day for 5 days from day 2 to day 6 of menses. And third is 10 tablet dose, long protocol, that should be started from the second day of menses, 1 tablet per day till for 10 days. Nowadays, in PCOS patient, if PCOS patient is unable to ovulate even after giving 10 days letrozole, we continue the letrozole till she ovulates. Other causes other than infertility, letrozole is also used for breast cancer, also used for males in oligospermia. If the male is having less sperm count, letrozole is also used in male problem also. In endometriosis patient also, letrozole is used. Male infertility, whenever you see the abnormal semen analysis, what medicines you can be given? Commonly given is clomiphene citrate, that is 25 mg tablet. Any clomiphene citrate 25 mg. Or nowadays we also give letrozole also. Second, commonly combined is coenzyme Q, reduce CoQ10 along with some antioxidants. And if the E2 testosterone ratio is decreased, or patient male is having hypogonadism, FSH LH level are decreased, then we give injectable in such patient in the form of SCG or FSH or HMG depending upon the hormonal level of the patient. Also, if there is an addiction, it is better to quit the addiction. So de-addiction is also important part in male infertility. Surgical treatment is required for the only varicocele patient of more than grade 2, and those patients of azoospermia, they require PESA or TESA, that is used in IVF, test tube baby. IUI, this is commonly used in infertility patients. So what are the indications for IUI? So commonest indication for IUI is unexplained infertility. Second thing, you are observing on the follicular study, patient is ovulating, but still they are not able to conceive. In such, after trying for 2-3 follicular studies with planned relation, we switch over that patient to we advise that patient to go for the IUI. IUI means intrauterine insemination of the semen. This can be of husband semen, this can be of donor semen. Donor semen IUI is for azoospermic patients or patients with very less sperm count but not going for IVF. Then in such cases also we do IUI. So what are the contraindication for IUI? So for IUI, fallopian tube should be patent. Both fallopian tubes should be patent. If the tubes are blocked, then you can't do IUI. You have to go for the IVF, in vitro fertilization. Success rate of the IUI is per cycle 15. If you are doing IUI at good center with good embryologist, good lab, then success rate is around 15 to 20%. Procedure details of the IUI. In IUI, we collect the sperm of the husband in a jar. We wash that sperm with some media. After washing the sperm, again we add some media into that sperm that causes the increase in the motility of the sperm. The bad sperms, dead sperms or abnormal sperms are washed out, and only good quality, good motility sperm are inseminated in the uterine cavity with the help of some silicone catheter. This is a very simple procedure. This procedure does not require hospitalization. This procedure does not require any anesthesia. This procedure does not require any bed rest. Those patients who are unable to conceive with the IUI, we try maximum 6 IUI if the patient is less than 30 years, maximum 3 IUI if the patient is more than 30 years. In some patients, even if tubes are blocked, then they are direct indication for the in vitro fertilization, or AMH is very low, they are unable to ovulate in spite of giving injection, then again it is an indication. If the fallopian tube are absent, of the ovaries are absent because of surgery, then again it is the indication for IVF. Now, there are different types of IVF: self IVF, donor IVF, and embryo adoption. Self IVF means eggs of the patient, some sperm of the husband. Donor IVF means one gamete, maybe egg may be of another patient or another donor, or sperm may be of the donor. And third is embryo adoption. In embryo adoption, even eggs or sperm are not of the couple. The success rate differs from the different types. In self cycle, approximately, if you are doing good IVF at good center, the success rate of self cycle is approximately 35 to 40%. If you are doing IVF at good center, then success rate of IVF with donor oocyte is approximately 65%, and embryo adoption is approximately 80%. If there is in the uterine cavity is normal, or patient is not able to form the endometrial lining, or there is absence of uterus, or there is because of some mishap you have to remove the uterus, then such patients are posted for surrogacy. Nowadays, commercial surrogacy is banned. Only altruistic surrogacy can we do you can do surrogacy in relative only. For any queries, you can contact me on my personal mobile number. You can WhatsApp me. You can chat with me. Thank you so much for your hearing.
Thank you,
If
sir.
any
Thank
question,
you.
please let me know.
Yes, sir. Thank you, sir. Thank you very much for that wonderful presentation, sir. For you have shown light on a few areas where still the doctors need to evaluate the fertility patients in a better way, sir. Thank you, sir. Sir, let me wait for 1 or 2 minutes for the participants to post their queries, sir. If there is any queries, then I'll read it for you, sir. Sir, the meanwhile, can I play a 1-minute video of our Shield Healthcare product, sir, so that
no problem.
yes. sir. Thank you for allowing us to play our product video, sir. And sir, I have 3 or 4 questions for you on the session, sir. Like you were saying that if the woman is having ovarian cyst on day 2, and we should not go for clomiphene citrate or this letrozole, sir. So actually, what should be the treatment for that kind of patients, sir?
If there is cyst on day 2, then that cyst needs to be treated first, and in next cycle you can start with the ovulation induction.
Okay, sir. Sir, if your patient is coming with hyperprolactemia and hypothyroidism, which one has to be ruled out first, sir? Whether the hypothyroidism or the
Both need to be treated simultaneously. Hypothyroidism takes time to get treated, but hyperprolactemia gets treated immediately. In 1 or 2 days, if the levels are less than 100, so hardly 2 or 3 doses are required to become it normal. 2 doses of cabergoline.
Okay, sir. And sir, what will be the role of adjuvants in infertility patients, sir? Like minus adjuvants,
Amino
sir.
acid.
Adjuvants, yes, sir.
Adjuvants are definitely important because they decrease the free radicals, they decrease the toxins from the body, they neutralize the toxins, and they, because of antioxidants, the quality of the eggs or quality of the sperm increases. They are important for the important at the level of mitochondrium, that modulates the egg potential or sperm potential. So in infertility treatments, adjuvants, antioxidants are very important, plays an important role. And in India, the no one's diet is perfect. So
Yes,
it plays a very important role.
yes, sir. So the next question is when it comes to male infertility evaluation. So how important it is to evaluate this sperm DNA fragmentation, so fragmented DNA in the
We
sperm?
do sperm DNA fragmentation in a patient who are having recurrent miscarriage 1, who are having less count 2, or failed IVF patients. The patient first cycle was failed. There was no formation of the embryos, or embryos were not of the good quality. Even there is a normal sperm count and normal eggs. In some patient, in this patient, we tell them to go for the sperm DFI test. If DFI is more than 25%, you can proceed with the treatment. First, you have to treat the DFI. Once it becomes DFI becomes the less, then you can go ahead with the treatment of the infertility.
Okay, sir. And sir, any special consideration for fertility evaluation in women with PCOS, sir? Women with PCOS, polycystic ovary, yes, sir.
Polycystic ovary, if the polycystic ovary is 2 types, one is clinical and one is only reports polycystic ovary. On report, it is showing polycystic ovary, but patient is not either having any symptom, not having any signs on the body of the polycystic ovary, then that woman needs to do only lifestyle modification. Just see the whether her weight is normal according to her height or not. If the weight is more, she needs to reduce the weight. She needs to exercise daily for at least 45 minutes and avoid the fatty foods like pizza, burger, or butter, or ghee. If there are symptoms, along with the reports, if the patient is having symptoms of PCOS like oligomenorrhea, irregular menses, scanty menses, if there is hirsutism, then that patient needs to be treated with the medicine in the form of minoxidil, metformin, depending upon the situation of the patient. And many patients require hormonal pills to regularize the menses and to decrease the volume of the ovaries.
Okay, sir. And sir, one last question is whether we have to evaluate both male and female simultaneously, or we can just evaluate the female first and then go for male
It
infertility.
is always simultaneously. In first visit, you need to evaluate both, because many times what happens, 6 months, 7 months of the time you are treating with the female or you are evaluating the female, and suddenly you see the husband comes, and if you evaluate the male and you find that there is 0 sperm count or there is very abnormal sperm count, then you have lost all these precious 6-7 months.
Yes.
If the parallelly, if you treat them, you will consume your time, and that is very important, because as age advances, AMH of the female decreases and fertility potential decreases. So it's always better to evaluate simultaneously. At least one semen analysis of the husband from a good lab is very important.
Yes, sir.
If preferably, if embryologist available nearby, you should do a semen analysis with the embryologist or MD pathologist who is doing regularly semen analysis.
Okay, sir. And sir, fine, sir. There is no other questions in the chat box, sir. So if you allow us, then we can end the webinar
Yeah.
for today, sir. Thank you.
Again,
very
thank you
much.
so much, Shield, for
Yes,
allowing
sir.
me this to conduct this webinar.
Yes, sir. Thank you for very much for being with us today, sir. You have spent your valuable time with us today, and also I can see many participants who are actively participating in this webinar, sir. So thank you, participants, and I thank my Shield team for making this webinar possible, sir. Thank you. Thank you very much, sir.
Okay.
Thank you, sir.
Thank you, sir.
Thank you.